To all my dear mothers, fathers, grandparents, teachers, and childcare providers everywhere, it's my pleasure to share with you this educational video about another serious mental disorder that affects many children and adults in our societies all over the world. This disorder causes significant distress and dysfunction in the lives of those who suffer from it and in the lives of their families. My name is Dr. Maher Kosman, and I've been a practicing board-certified child psychiatrist in the state of California in the US for the last 31 years. And I will be sharing with you from my experience as well as review of the literature and latest research what we know about post-traumatic stress disorder in children and adolescents. The title of our topic is, Does your child suffer from PTSD or post-traumatic stress disorder? And in this video, we will answer the following questions. What is post-traumatic stress disorder? How prevalent is this disorder in children? What are its predisposing factors? Are there any common comorbid disorders? What causes it and how does it develop? What are its symptoms, course, and its effects? And at last, how do we diagnose it and how do we treat it? Let's first get to know what is post-traumatic stress disorder or PTSD. PTSD is a chronic debilitating condition that affects some children and adolescents after exposure to a serious traumatic event that may be an abusive experience or a bodily assault or threat of assault experienced directly or witnessed, or due to a national disaster. Most children experience one or more traumatic events throughout their lives until they reach adulthood, but only few suffer from PTSD. This disorder increases the occurrence of other psychiatric disorders and risk of suicide. It may affect the ability to function at school or work, or decrease one's social and economic opportunities, and may even trigger an early onset of chronic heart disease and other medical disorders. But you may want to know, how prevalent is PTSD among children and adolescents? It's been found that exposure to trauma varies widely internationally. A US nationwide study of over 6,000 adolescents reported that 62% of youth experienced at least one traumatic event in their lifetime, and 19% have experienced 3 or more such events. A national survey in Mexico reported that almost 69% of children were exposed to a traumatic event. A 2019 survey of 2,232 children, representative of a birth cohort in the United Kingdom, reported a lower prevalence rate of 31.1%. Also, similar low prevalence rates have been reported in other European countries like Germany. Prevalence per gender shows that 15 to 43% of girls and 14 to 43% of boys have been exposed to one traumatic event in their lifetime. And about 3 to 15% of girls and 1 to 6% of boys exposed develop PTSD symptoms. More frequent national disasters lately have caused increase in traumatic events and its devastating sequelae for children. An analysis of about 43 studies published in 2014 showed that 16% of children exposed to trauma actually developed post-traumatic stress disorder. The risk of exposure to trauma also varies per children characteristics, as well as characteristics of their families and social environment. Rate of exposure is the same among girls and boys, but girls are more exposed to sexual assault and boys are more exposed to physical violence. Uh, Young children are more exposed to physical abuse by a caregiver or witnessing domestic violence or even to kidnapping, and about 50% of young children are exposed to these things before age 8. Adolescents, on the other hand, are at more risk for sexual assault, external violence, receiving emergency treatment for a serious illness, or having unexpected loss of loved ones. Children exposed to traumas that include personal violence or abuse or sexual assault from a caregiver are more likely to suffer PTSD by a rate of 30 to 70%. Also, studies of children exposed to war show a PTSD rate up to 47%. And the rate among children who are drafted as soldiers in war zones is between 35 to 97%. It's also been found that children exposed to more than one trauma are more likely to develop PTSD compared to those exposed to only one traumatic event. But you may ask, what are the risk factors that may make some children more susceptible to PTSD? Certain psychiatric disorders were found to place children at risk for exposure to traumatic events, as will be discussed later. Alcohol and drug use are associated also with increased risk for experiencing interpersonal violence, as well as accidents and injuries. Certain family characteristics, especially children who are not living with both biological parents due to parental separation or divorce, seem to be at risk for inadequate supervision and maltreatment by step-parents or caregivers or strangers at home. Children living in urban areas or war zones are at higher exposure risk as well. There are more than 230 million children who live in regions impacted by war and armed conflict. And since child abuse is considered one of the traumatic events that children may be exposed to, let's review how widespread is child abuse in the United States. Child Protective Services agencies in the US receive close to 3 million reports of suspected abuse annually. These reports include 5.5 million children, and for 30% of these reports, child abuse is confirmed. And types of child abuse include neglect in 65% of cases, physical abuse in 18% of them, sexual abuse in 10% of cases, and emotional or mental abuse in 7% of these cases. Also, 1 in each 3 or 5 children, depending on the study that was done, is a victim of bullying, which can cause lifelong psychological damage. About 40% of girls and 27% of boys exposed to bullying experience PTSD symptoms. And considering how traumatic national disasters can be, let's look at the impact of the corona pandemic on children. According to a survey conducted in China during the pandemic that included 359 children and 3,254 adolescents. Ages of all these kids varied from 8 to 17 years. They found that 22.3% had symptoms of depression, which is higher than the usual rate of 13.2% before the pandemic. Also, anxiety rates were found to be higher. Another internet survey that was conducted in China among 8,079 adolescents showed that 44.7% had symptoms of depression, 37.4% had symptoms of anxiety, and 31.3% had a mix of both. A prevalence of 9% in the general population were found to have symptoms of PTSD in connection to COVID-19 outbreaks. But definitive prevalence rates among children are lacking, but a survey in China among 688 children ages 7 to 15 years showed that 20.7% of them have experienced PTSD symptoms. Continuing to look at what makes some children more vulnerable for PTSD, girls are found to be 2 to 3 times more likely to develop PTSD compared to boys, even after accounting for their higher exposure to rape and sexual assaults. But no clear explanation found yet to explain the difference. Also, children with history of other mental disorders are more likely to develop PTSD following exposure to a traumatic event, especially those with anxiety disorders, mood disorders, impulse control and conduct disorders. And these latter two groups of impulse control and conduct disorders tend, as you know, to increase risk of exposure to accidents and violent encounters. How about family characteristics that make some children more vulnerable for PTSD? Studies have shown that poor family functioning is a risk factor for PTSD in children exposed to trauma. Also, parents' reaction patterns to trauma are also associated with PTSD risk in their children. Parents themselves may develop PTSD, depression, or anxiety symptoms following their child's exposure to trauma, as they often experience the same traumatic event with their child. On the other hand, children who have greater social support are less likely to develop PTSD than those with limited or without social support. One may ask here, how about the effect of a child's response to trauma on the risk for PTSD? Cognitive and emotional responses to traumatic events have been associated with increased risk for PTSD in children. An example for these are higher level of anger related to the trauma, increased ruminations or tendency to think a lot about the trauma, also more negative appraisals of the trauma, also experiencing dissociation during and after the traumatic event, and experiencing higher heart rate when presenting to the ER for injuries as a result of the trauma requiring hospitalization. Another factor is greater engagement in avoidant coping strategies, and this have been found to be associated with later onset of PTSD. But how likely it is to find other comorbid mental disorders with PTSD or that accompany PTSD? Child PTSD frequently presents with other comorbid disorders like anxiety disorders, depression, externalizing behavior problems, also substance use disorders among adolescents, as well as self-harm and suicidal behaviors. In an epidemiologic study of a representative US population sample of about 1,420 children, about 35% of them with PTSD also met criteria for another psychiatric disorder. The likelihood of comorbidity also increased with higher number of lifetime traumatic events. And here comes an important question that many of you may be asking, which is, what is the pathophysiology or mechanism of formation and development of post-traumatic stress disorder? The precise physiological process that explains the formation of PTSD is unknown, but a prominent learning model theory that explains PTSD reflects a failure to inhibit fear. Traumatic events can cause fear conditioning in a way so that sights, sounds, smells, and people present during the experience become cues associated with intense fear and arousal experienced during the trauma. For most, these fear responses diminish over time as a result of extinction learning through the generation of novel associations that compete with the original fear. For children with PTSD, the original fear memory continues to overwhelm the extinction memory and extinction learning process, possibly due to a weak extinction memory, even in presence of safety cues. Evidence for this model is seen in the behavior of adults and in the neuroimaging of their brains, revealing disruptions in structure and function of brain regions involved in fear learning that we see it here at the right-hand side of this slide, the amygdala, also the hippocampus, the anterior cingulate cortex, and also the ventromedial prefrontal cortex, VMPFC. PTSD is found to be associated with increased activation of the amygdala that we're pointing at in this diagram of the cross-section of the brain at the right top section of the slide, as well as reduced activity in the ventromedial prefrontal cortex and the rostral anterior cingulate cortex in the lower image of the cross-section of the brain in response to emotional or threatening cues. Also, it was found to be associated with increased activity in the dorsal anterior cingulate cortex that we're pointing at in the lower image in this slide during fear conditioning, extinction learning, recall, and response selection. There's also been observed reduced hippocampal volume of the hippocampus in this area that we're pointing at here in the top image in individuals with PTSD. But the extent to which these disruptions in neuronal function represent vulnerability markers for the disorder or consequences of trauma exposure or related to PTSD onset is really not known. Another brain circuit involved is the hypothalamus pituitary adrenal axis that we see here in the diagram at the right-hand side of this slide. And the HPA axis plays a major role in the fight-flight stress response to threat or trauma. The HPA axis is modified by the prefrontal cortex and hippocampus. Both decrease its activation, while the amygdala activates the hypothalamus, especially the hypothalamic paraventricular nucleus cells, upon exposure to trauma or threat. When the hypothalamic paraventricular nucleus cells are activated and the hypothalamus, CRH or corticotropin releasing hormone is released, and it affects the anterior pituitary gland to release a hormone called ACTH or adrenocorticotropic hormone, which stimulates the adrenal gland to release glucocorticoids, including cortisol, which regulate the body's immune response, metabolism, and other brain functions. Increased cortisol levels trigger negative feedback signals to the hypothalamus and anterior pituitary to reduce levels of CRH and ACTH and bring balance back to the circuit. If the hypothalamic paraventricular nuclei are repeatedly activated, this leads to disruption of glial cells functions and also formation of dendrites, which eventually lead to chronic deficit in cortisol levels. And this what has been found as a marker in studies of veterans with PTSD. So in summary, all these neuronal functional changes reflect disruption in the HPA axis response to stress and suggests low cortisol levels as a marker in those who are susceptible to PTSD. But how does PTSD manifest and what are its symptoms? There are 4 groups of symptoms. The first group is group of intrusive symptoms, which reflect persistent uncontrollable thoughts, dreams, and emotional reactions about a traumatic event. These symptoms are the hallmark of PTSD and distinguish it from other anxiety and mood disorders. Second group is the group of avoidance symptoms, which often develop to avoid situations, people, places, or anything that triggers memories of the trauma. In young children, avoidance may manifest as restricted play or reduced exploration of their environment. Third group of symptoms uh, include changes in emotions and thought patterns, and that occur frequently in children with PTSD, like increase in negative emotions, An example for that, emotions of fear, anger, guilt, and shame, as well as reduction in positive emotions like happiness, excitement, and love, with diminished interest or motivation to engage in activities they used to enjoy before the trauma. It may be also more difficult for children to feel close or connected to loved ones, resulting in feelings of detachment or estrangement. They may also develop negative beliefs or attitudes about themselves, others, and the world around them, like beliefs that they are bad or that they are damaged by the trauma, or that others can't be trusted, or that the world is an unsafe place. The fourth group of symptoms includes symptoms of increased arousal and emotional reactivity, like irritability, anger outbursts, or becoming physically aggressive more frequently than typical before the trauma. This reactivity can interfere with their peer relationships. They may also experience exaggerated emotional and physiologic reactions to unexpected stimuli, including heightened startle response and increased risk-taking behaviors, especially in adolescents. Also, concentration problems that interfere with school performance are common, and becoming fearful of strangers, as well as developing separation anxiety and sleep problems, are frequently seen in children with PTSD. It's also important to know the course of PTSD and how it progresses. The course of PTSD is highly variable. Most adolescents who develop PTSD recover from the disorder, but one-third experience a chronic course that may last many years. Factors that predict a chronic illness include exposure to additional traumatic events after developing PTSD, also manifesting in a greater way avoidance symptoms. Uh, Another factor is incident anxiety and also somatoform disorders after onset of PTSD may predict a chronic course. Also living in poverty and having a co-occurring bipolar affective disorder. So how do we diagnose PTSD in children and adolescents? If your child was exposed to a traumatic event and started showing any of the symptoms previously described, he or she should be evaluated by a therapist or child psychiatrist to make the appropriate diagnosis and ensure that these symptoms are linked to the traumatic event and not due to another mental disorder. Assessment should focus on intrusive symptoms, strong reactivity to trauma cues, also nightmares, repetitive play of the events of the trauma, as well as avoidance of trauma reminders, and hypervigilance. Symptoms to be checked against the DSM-5 criteria with screening for suicide risk as well as for other comorbid disorders. Assessment tools may be used like the UCLA Post-Traumatic Disorder Reaction Index and also the CAPS CA5, which is the Clinician Administered PTSD Scale for Children and Adolescents over age 7. According to the DSM-5 criteria for PTSD, The PTSD criteria include 4 core clusters of symptoms that we have previously described: intrusion, avoidance, negative alterations in cognition and mood, and hyperarousal symptoms. And to meet the diagnostic criteria, there needs to be A, exposure of the child or his or her loved one to a threat of injury or death or serious injury or violence or sexual assault directly or as a witness or learning about it. B, one or more symptoms of the first 2 clusters and 2 or more of the latter 2 clusters to meet the criteria. And symptoms need to be present for 1 month or more and cause significant distress or impairment of functioning and not attributable to other mental or medical condition. Having diagnosed post-traumatic stress disorder leads us to the next step, which is how do we treat it in children and adolescents? First line of treatment for PTSD that is evidence-based is TF-CBT or trauma-focused cognitive behavioral therapy. This modality may be offered individually or in group format and can be tailored to meet the needs of specific subgroups. Another proven therapeutic modality is EMDR or eye movement desensitization and reprocessing therapy. Explanation of how each of these 2 modalities works to follow next. First, we'll start with what is trauma-focused CBT or cognitive behavioral therapy. Trauma-focused CBT is based on reversing the fear conditioning processes that become overgeneralized and difficult to extinguish as a result of the traumatic event. And since biological, learning, social, and environmental factors are implicated in the disorder formation, there is a need for focused and precise approaches to this treatment modality. The model incorporates cognitive behavioral, developmental, neurobiological, attachment theories, as well as family interventions. Treatment targets include gaining resilience and coping skills, mastering learned and overgeneralized avoidance behaviors, acquiring adaptive meaning of the traumatic experience, and resuming optimal developmental trajectories. This is achieved through completing 3 phases of treatment. The first one is stabilization phase. The second one is trauma narration and processing. And the third one is integration and consolidation phase. And the treatments is provided over 12 to 25 weekly sessions. And components of treatment are referred to by the acronym P practice. The first P stands for psychoeducation. The second P is for parenting skills. The R is for relaxation skills. The A is for affect modulation skills. The C is for cognitive processing skills. The T is for trauma narration and processing. The I is for in vivo mastery of trauma reminders. The C is for conjoined child-parent sessions. And the E is for enhancing safety. As for EMDR therapy or eye movement desensitization and reprocessing therapy, it differs from trauma-focused CBT and the following. First, it incorporates saccadic eye movements during exposure to trauma memories while following the therapist's bilateral finger movements. Second, the trauma narrative is completed differently, with the child recalling an aspect of the trauma with focusing on associated cognitions and on arousal while visually tracking the therapist's finger. Third, parental involvement is optional. Fourth, treatment duration is shorter, usually around 8 sessions compared to the 24 sessions in trauma-focused CBT. But both modalities are proven equally effective. And you may ask, are there any contraindications to trauma-focused CBT? There's actually no absolute contraindications, but some relative contraindications to the use of trauma-focused psychotherapy. First one is that comorbid disorders presenting acutely and requiring immediate stabilization, like acute suicidality, psychosis, mania, or drug intoxication, will make it very difficult to use this modality until this condition is stabilized. Second one is that if there is any severe developmental or cognitive impairment, which will interfere with the child's ability to engage in this treatment modality. The third one, conditions that would interfere with participation in group format, if that was the only treatment modality available, like those children who have severe ADHD won't be able to stay focused and engage in the treatment process. And here comes an important question, which is, what are the medications proven effective for PTSD, if any, in children and adolescents? Looking at selective serotonin uptake inhibitors, or SSRIs, which have been proven effective for treatment of PTSD in adults, it was found that they do not appear to be effective in children with PTSD. But an open, uncontrolled study of 19 children ages 6 to 18 with PTSD symptoms who were treated with 1 to 4 milligram of guanfacine extended release at bedtime for 8 weeks showed significant reduction in their re-experiencing as well as avoidant and hyperarousal symptoms of PTSD that they have had. And that is with using the UCLA reaction index scale. Case reports and retrospective case series also suggest that prazosin or minipres, which is an alpha adrenergic antagonist, may be effective for sleep disturbances, especially in reducing nightmares. There are also limited uncontrolled medication trials of second generation atypical antipsychotic medications in youth, like Abilify and Risperidone, that's been tried for those who have PTSD symptoms. But those trials produced mixed results and high rates of treatment emergent adverse events. But a small open label trial of divalproex, or Depakote or Depakine, and also a retrospective evaluation of carbamazepine trial showed improvement of PTSD symptoms in youth with PTSD. But we have to caution that these studies were performed in settings where intensive psychiatric services are provided and where there was also high comorbidity, so the results cannot be generalized for other settings. According to Peter Levine, trauma is a fact of life. It does not, however, have to be a life sentence. So let your healing start now. And here's a list of the references for all of the information provided to you in this educational video. At the end, I want to thank everyone who joined in watching and listening to the content of this video. And for any questions or comments, please contact us at ped.psych101@gmail.com. We also invite you to visit our YouTube channel and subscribe for free at Know and Grow with Dr. K. And until we meet in another episode, uh, my best wishes to you and your loved ones. Thank you.